Assalamu alaikum. Good morning, everyone. My name is Ghazal. I'm an R4 resident in the Saudi board. Today, we'll be talking about approach to tinnitus. And the tinnitus we're actually talking about today is the tinnitus that is primary with an unknown cause. Otherwise, we will manage accordingly.
Recording in progress.
So first, we're going to talk about some definitions, classification of tinnitus, history and physical examination, and then management and guidelines of tinnitus. So tinnitus is a common condition that affects almost 30% of people older than 55 years old, and it's a very common complaint that we usually face in our clinic. It is usually thought to be, the theory adapted is that it's an over-adaptation of the auditory center to hearing loss. So most of the patients who are complaining of tinnitus will be having also sensorineural hearing loss. Differential diagnosis and associated factors of tinnitus are broad. Therefore, they require a very thoughtful and standardized approach to evaluate and manage these patients. History is really important when facing a patient with tinnitus because it will always guide us to what to do next. So we consider the treatment of tinnitus successful if it relies on, first, to identify the cause, then to treat the exacerbating or causing factors, and lastly, we rehabilitate the hearing loss if present. We try to educate our patients how to adapt to their condition if it was untreated. Starting with some definitions, tinnitus is usually described as the perception of sound when there is no actual external stimulus or no actual external source of sound. We can classify them into primary and secondary tinnitus. Primary tinnitus, as we just mentioned, is the idiopathic part or the idiopathic type that may or may not be associated with sensorineural hearing loss. On the other hand, secondary tinnitus is the tinnitus that is associated with a specific underlying cause or an identifiable organic condition. We can also classify tinnitus into recent onset or persistent, and it depends on the duration of the complaint. Less than 6 months is considered recent, and more than 6 months is considered persistent tinnitus. Other used definitions are the bothersome tinnitus and non-bothersome tinnitus, and these are the two descriptions used to describe the tinnitus affecting the patient's life. Mostly the patients that we're going to see in our clinic are the type of bothersome tinnitus because this is why they start to seek medical advice when it becomes distressing and affects the quality of life. Other classifications, we can use subjective versus objective, pulsatile versus non-pulsatile, primary versus secondary, and these are used together rather than separately. So subjective tinnitus is the tinnitus that is only heard by the patient, where objective tinnitus is the tinnitus that is also heard by the physician, and it's usually caused by turbulence in the blood flow. So it's kind of translated into the bruit that we can auscultate with the patient. Pulsatile versus non-pulsatile related to the heart rate. So pulse. So when we ask the patient in the clinic, these are really important questions to ask when we analyze the complaint. Primary versus secondary, as we just mentioned, primary is the type that is idiopathic and no underlying organic dysfunction that is seen, where secondary is usually due to an organic cause. So 90% of all the tinnitus is usually subjective, which is heard only by the patient. Non-pulsatile tinnitus, this is the most commonly faced tinnitus in the clinic. Moving to history and physical examination, of course, when we face a patient who is complaining with tinnitus, we have to analyze the character of the tinnitus in terms of onset, nature, whether it's pulsatile or not, site, whether it's unilateral, bilateral, whether it's progressing or it's the same since onset. Associated symptoms including all otological complaints, including hearing loss, vertigo, focal neurological symptoms, and ear pain or discharge. Risk factors including medications, trauma, occupation, or recent surgeries or procedures done in the ear or other way. The significance of each finding, for example, if tinnitus was unilateral, then we usually suspect a secondary cause. Next steps will be discussed later on. For example, persistent, more than 6 months, unlikely to resolve spontaneously, which will help us when counseling the patient. If it's pulsatile, then we also suspect a secondary cause, particularly usually vascular etiologies. Vertigo, usually we suspect cochlear or retrocochlear or central nervous system causes. Hearing loss is frequently encountered in patients with tinnitus. The significance of hearing loss will also help us in managing the patient later on, plus identifying the real cause. Um, So there were multiple questionnaires that were used before. These questionnaires will help you first determine the severity of the tinnitus, whether it's really affecting the patient's life or not, and later on will help you determine whether your management had actually made the difference with the patient or not. The most recent one is the tinnitus functional index, which uses almost 30 items with 8 subscales, ranging from 0 to 10, where 0 is none and 10 is maximal. It usually discusses multiple items, including feelings of the patient, their hearing, whether it's affected or not, their quality of life, sleeping, their ability to manage tinnitus or not. And as you can see here, the patient can scale it from 1 to 0, and then we can identify whether it's actually disturbing the patient or not, and if our management is actually causing a difference or not. Moving on to physical examination. Of course, physical examination should be aimed at screening for secondary causes, because primary idiopathic tinnitus is usually a diagnosis of exclusion. So once we face a patient with tinnitus, it's more important that we rule out more serious causes in the clinic, so we can later on counsel with the patient on how to adapt to the tinnitus if there were no obvious causes. So we will start with, of course, routine head and neck examination, focusing mainly on the ear. We will use an otoscope, of course, to assess the tympanic membrane for its integrity, movement, and presence of any suspicious masses. Tuning fork exam will assess hearing impairment. Pneumatic otoscopy can be used if we suspect the presence of fistula, so we can assess for torsional nystagmus. Of course, neurological examination is really important to rule out any focal neurological signs, including cranial nerve palsies. TMJ assessment can also be helpful, because sometimes it's the TMJ dysfunction will also cause some sort of tinnitus. Because the issue with tinnitus that we usually face, the description of the tinnitus differs from one patient to another. So it's really important to try to identify the proper, the sound that they usually perceive, whether it's a clicking sound or is it a ringing sound. Last but not least, we can also auscultate for any brewery just to determine whether objective or subjective tinnitus. So the question that we usually face is that should audiological assessment and imaging be done for every patient complaining of tinnitus, or is it special to a certain type of patients? So according to the American Academy, the history and physical examination is strongly recommended in every patient who is complaining of tinnitus. Of course, these are the recent guidelines when we manage tinnitus. So prompt audiological examination, meaning that comprehensive audiological in terms of tympanometry and audiometry, it is strongly recommended to be done in patients with tinnitus that is usually unilateral, persistent, and or associated with hearing difficulties, where in other patients it's usually optional. So unilateral, persistent, with hearing loss is recommended to do audiological testing. Imaging is usually there is recommendation against routine imaging. It is usually preserved to patients with a high suspicion. So patients who have one or more of the following are usually candidate for imaging. Tinnitus that localizes to one ear, pulsatile in nature, associated with focal neurological abnormalities, or asymmetrical hearing loss. So there is a strong recommendation against routine imaging. So other audiological assessment, as I just mentioned, will include pure tone audiometry and tympanometry. The recommended imaging options in case of asymmetrical sensorineural hearing loss, MRI is recommended, because then we will be suspecting vestibular schwannoma, and it's really sensitive in diagnosing it. In cases of pulsatile tinnitus, the optimal initial imaging modality is still controversial, but CT angio is usually used in these patients. So again, as I just mentioned, the successful management of tinnitus relies on First, identifying the main reason or the main underlying cause, treating it properly. In case of undetermined or unknown cause, then the treatment of exacerbating or causal factors will actually achieve a successful management. Our goals in managing patients are first, amplification of hearing loss if present, then to educate the patient on how to cope or adapt with the tinnitus, and a cognitive behavioral therapy for persistent bothersome tinnitus. These are the goals of we try to achieve when we manage these patients. So, hearing amplification. If the audiogram reveals asymmetrical sensorineural hearing loss, then hearing aid amplification can be helpful in both management of tinnitus and hearing deficit, which will bring us back to the theory that was adapted that tinnitus in origin is usually a adaptation of the auditory system into hearing loss. So some kind of patients usually respond well to hearing aids. Improves subjective tinnitus hearing loss and hearing loss by 50 or 85%. Hearing aid is the used method to amplify. And then we also have the options of maskers, in which the idea with the maskers is that they create a sound within the same threshold that the patient actually experiences tinnitus in. So it creates a background to actually distract the patient from focusing on the tinnitus that they're complaining of. This is usually used in patients who have tinnitus with normal hearing. One suggestion is that hearing aid and maskers can be used together to achieve يعني tinnitus free what we call it tinnitus free interval and amplify the hearing loss. Cochlear implant is usually used in patients with single-sided deafness and tinnitus. It was seen that patients had initial improvement in 38% to 85% of cochlear implant recipients, with up to 93% of patients reporting tinnitus suppression after 2 months. So improvement was seen in almost 85 and complete suppression in 93% of patients. There are rare cases where patients can't develop tinnitus or exacerbate the tinnitus after the cochlear implant. It was seen more with the bilateral cochlear implant rather than single-sided cochlear implant. This study was conducted in Switzerland, where they had 174 cochlear implant candidates who underwent CI surgery, and then they were followed in 2 sessions. One was they were seen once preoperatively and then reassessed again 6 months after the device activation. In both sessions, tinnitus was assessed in terms of loudness using the visual analog scale and standardized questionnaires as the ones we saw in the beginning. It was seen that almost 71.8% of subjects reported tinnitus preoperatively. 6 months after CI surgery, 20% of these patients reported complete abolition of their tinnitus, where 51% they reported just subjective improvement, where 21% no change, and 7.2 were deteriorated and became worse. Of the 48 patients who had 48 patients had no tinnitus preoperatively, only 5 of which developed tinnitus 6 months after CI. Then we're going to talk about the cognitive behavioral therapy, which is an option we can offer our patients. It usually focuses on turning the negative ideas or negative thoughts into positive ones. It actually helps patients to adapt with their tinnitus. CBT typically is weekly sessions from 60 to from 1 to 2 hours. Where we teach patients how to adapt with their tinnitus rather than the tinnitus being a negative, whether having a negative impact on the patient. For medical treatment, still there are no FDA-approved medications to treat tinnitus. What we usually do is that if the patient had comorbid psychiatric illness, such as anxiety or depression, it should be treated accordingly by psychiatry. So routine antipsychotic medication used in patients who are complaining of tinnitus is not recommended. Dietary supplement. It's not routinely used as they might cost, and then they might also interact with other medications that the patient is receiving. So important thing to note that when obtaining a history, we should also ask thoroughly about the medications that the patient is receiving, um, because it may interact with other treatments. So dietary supplements will include zinc, magnesium, melatonin, multivitamins, and herbs, including the ginkgo biloba, which we'll talk about later on. Um, Zinc usually is a metal that will, and it has a role against antioxidant. It would, يعني honestly, most of the dietary supplements were found to have no benefit if the patient had no other comorbidities. يعني it has no clear benefit, so there were no clear recommendations whether they're recommended or recommended against. Melatonin is a hormone secreted by the pineal gland, which is involved in the sleep-awake cycle. Studies only showed that it's benefiting patients who are complaining of tinnitus along with insomnia. So tinnitus alone, there were no studies that recommended using melatonin. Ginkgo biloba contains flavonoids and terpenoids, which are antiplatelet and antioxidants and antihypoxic properties. The theory is that they improve the circulation, so it might help. So again, no clear recommendations made against or with its use, actually. One thing to note that it may cause a synergistic effect with anticoagulants or antiplatelets, so patients should be aware of this fact in case if they're taking any of these medications to avoid using the ginkgo biloba. So again, this is another study conducted in patients who had Alzheimer. The study included, it had 3 trials with 1,143 participants. They included patients for 2 types of patients mainly. The first group were the patients who primarily complained of tinnitus, and the other group included patients with mild to moderate dementia. Some of these patients had tinnitus, so their primary complaint was dementia rather than tinnitus. There was no evidence that ginkgo biloba was effective in the first group with the primary complaint of tinnitus. Small but statistically insignificant reduction of only 1.5 to 0.7 points was seen in patients taking ginkgo biloba with vascular dementia or Alzheimer's disease. So the actual benefit was seen in the other group rather than the first group. But again, there are limited evidence, limited studies. We cannot actually recommend against or with the use of the ginkgo biloba. So some of the physicians use it as a placebo just to help the patient adapt with their tinnitus. The other element we have to cover when managing patients is the patient education, and it's a really important aspect to cover when managing these patients. These are the points that we should discuss with patients in the clinic. First, we have to let them know what's the definition of tinnitus. Because there are different complaints, as I just mentioned. Tinnitus is actually the sound that is created in an ear or another. It is usually a symptom, not a disease on its own. People with chronic tinnitus usually hear it most of the time. For some people, it's just intermittent. There is one clinical symptom is a brief spontaneous tinnitus, in which it's just a clicking sound or just a second of tinnitus that disappears immediately with no with no effect. And people should also be aware of this condition. So transient ear noise is a sudden whistling sound accompanied by perception of hearing loss. This event is usually unilateral and seems to occur completely at random time without anything precipitating it. Often, these ears feel blocked during the episode, and symptoms generally disappear within a period of about a minute. And I'm sure all of us experience this symptoms. It's just a transient ear noise, sometimes called a brief spontaneous tinnitus, and that's a normal finding that does not necessitate any further investigation or management. Then we can also discuss the way we assess the tinnitus and the associated hearing loss. Patients with tinnitus commonly attribute hearing problems to tinnitus, so the clinician should determine how much of a patient complaint is due to the hearing problem rather than the tinnitus, so we can later on know how to manage the patient. tinnitus can be temporary, so patients might be given this tiny hope that it might disappear, and it might not, so they have to adapt with it. There is tinnitus-induced exposure, to loud noises can cause temporary threshold shift, as well as temporary tinnitus. So tinnitus that is usually due to exposure to loud noise will likely resolve within a few days following the insult. So repeated episodes of noise exposure will increase the likelihood that the tinnitus will become permanent. So it's in the beginning, it's just usually episodic, but if the patient keeps on being exposed to the same loud noise, then we might it might become more permanent. Drug interactions, also patients should be aware that some medications can cause tinnitus, and such type of tinnitus, it typically lasts 1 to 2 weeks post-exposure. Usually it's temporary, but can also be permanent, especially with those who are using ototoxic medications such as aminoglycosides or the cancer chemotherapeutic drugs, especially cisplatin. Aspirin is usually well known to cause temporary tinnitus, but there is a specific dose that we have to achieve, or there is a specific dose that causes tinnitus, not any dose. Usually it's not permanent, it's usually temporary. Um, so other multiple medications are found to cause a tinnitus, including NSAIDs, loop diuretics, drugs used to treat mental health and sleep conditions may also trigger or exacerbate a pre-existing tinnitus. One point to note or to discuss with the patients in the clinic is that we have to let them know that at some point there is no absolute cure for primary tinnitus. A cure for primary tinnitus still does not exist. We can help them to relieve their functional effects of the tinnitus, such as if they were having sleep disturbance, then we can offer them, as we said, melatonin. Difficulty concentrating or problems with hearing, we can offer them hearing aid. Patient needs to be informed that although tinnitus cannot be cured, there are still ways to learn how to manage their emotions, their reaction, and their negative ideas towards tinnitus. Of course, we can also just explain to them the theory behind or the pathophysiology behind the tinnitus, that it's usually a compensatory adaptation of the central auditory system to hearing loss. It helps a lot when the patient is aware of their condition. These are just summary of all the guidelines we just mentioned, put together in one schedule. And that's it. These are my references, and thank you very much.
Thank you very much, Dr. Ghazal. الله يعطيك العافية. يعني comprehensive, conclusive lecture. ما بعرف إذا عنده حدا أي comment أو أي question. I have always one controversial question about tinnitus. What about tinnitus that happens suddenly without sensorineural hearing loss? The sudden tinnitus, but the audiogram is totally normal. Do we treat it like sudden sensorineural hearing loss with giving steroids, or we just neglect it?
I actually read that they compared in one study. They compared the antitympanic dexamethasone injection with normal saline. They put people in 2 different groups, and they found that there is actually no significant effect on tinnitus on its own if it was not caused by, let's say, if the patient was diagnosed as Meniere, yes, sure, it will cause significant difference. But in an idiopathic tinnitus, they found that they injected one group with dexamethasone and another group with normal saline, and both had the same result. So there's actually no significant role of antitympanic injection in primary.
What about treating tinnitus after sensorineural hearing loss? Many patients come with sudden sensorineural hearing loss and tinnitus, and we give them steroids orally or intratympanic injections. After a couple of days, up to 1 week, maybe the hearing comes back, but the tinnitus continues. So do we continue treating the patient, or we stop at that point?
Well, from what I read is when we give steroids in this case, we're actually targeting the hearing loss because again, we go back to the primary theory in which they suggest that the tinnitus mainly was caused by the over-adaptation of the hearing loss. So it's just a trial just to fix the actual hearing loss. And in some cases, yes, even the tinnitus might decrease, but in a lot of cases, the tinnitus still persists. So I don't think it has an actual effect on the tinnitus itself. But if the tinnitus was actually caused by over-adaptation to the hearing loss, then yes, sure, it will cause a difference.
صباح الخير.
هذا دكتور حسام تفضل.
اهلين دكتور ابراهيم. طيب اولا غزل الله يعطيك العافيه، جود ريفيو صراحه ممتاز. في الاكيوت tinnitus and I've read before a study actually showed some benefit of intratympanic steroid. I have يعني minimal experience صراحه، ولكن في بعض الاحيان والله يعني في يعني very clear benefit. اخر اكزامبل يمكن لاست ويك انا جاني واحد من زملائي في الجامعه associate professor جاله وعنده chronic mild tinnitus وجاله يعني significant increase in the level of tinnitus. We did hearing test was completely normal, but because he cannot sleep even he يعني كان very focused on tinnitus وما قدر يعني manage. We tried the intratympanic steroid and 24 hours the tinnitus decreased to less than 50%. يعني was significant improvement. هو بنفسه جاء قال لي اقول لك اعطيني الثانيه، يعني انا I'm very happy with the result. واعطيته another one والtinnitus almost disappeared، يعني صار يعني very mild tinnitus. Is it again coincidence? Is it natural history? We have no idea. Is it placebo even? Not sure, but clearly he يعني showed clear benefit. I believe actually, and still again I don't have enough evidence، بس انه acute tinnitus can be managed by steroid. وزي ما قالت الدكتوره احنا المشكله we are treating symptoms not a disease, so because we don't know the underlying condition in this particular case, we are not sure if the tinnitus will disappear by treatment or not. But I start actually giving intratympanic steroid and systemic steroid for acute severe tinnitus. As I tell the patient, there is nothing to lose to try. أما بالنسبة للpersistent tinnitus after hearing loss, usually I treat it as a يعني كان لسه في شوية hearing loss, so I will taper down. يعني my protocol usually 7 days and stop. بس إذا كان ما زال عنده tinnitus أعتبره كأنه لسه still عنده a bit of hearing loss. لأنه في 8,000 frequencies, usually we will find some deficit. So that's why we continue giving steroid for another week or two. If he showed some improvement, at least we know that we addressed the disease process by the steroids, the hearing improved. So I assume that the tinnitus will improve as well because it's the same disease, it's the same condition. بس كل المشكلة الستيرويدز والhearing loss والtinnitus يعني فيها a lot of factors زي ما تكلمنا يمكن الأسبوع اللي راح. We are not 100% sure which patient will improve.
Thank you, Dr. Hussam. Another question about beta circ. I don't know, maybe I missed part of these slides, but did you mention any benefit of beta circ use for tinnitus, or there is no evidence?
No, I actually did not mention. I did not come across it when they talked more about the tinnitus. It was more of vertigo management. But maybe I missed it too. I don't know. ما أدري دكتور حسام
I don't know about your experience, Dr. Hussam. We use it very commonly. I don't know if there is any evidence.
ما في evidence. Honestly زي ما قال الدكتورة تقريبا ما في evidence for any medications. And I did one time actually an extensive review to all the tinnitus management. الميلاتونين كان فيه أعتقد one study will show some benefit. الجينكو بلوبا برضو كان فيه يعني very weak evidence إنه might work, but again يعني study تعتبر weak. Beta circ there is no clear evidence except if the patient has endolymphatic hydrops. Tinnitus will definitely improve significantly. But خليني أعطيكم حاجة من الهيومنايزيشن اللي استمتعنا فيها last week. And I usually treat the condition as a يعني زي ما تقول بتطالع في البيشنت as a كده as a human. فلما تعطي له reassurance مع some medications ويعني تقول له كده انه it will improve. يعني حتى لو انت تقصد انه it will improve with time, which is true most of the time, and take these medications including مثلا البيتا سيركوجين, which I usually give honestly حتى انا عارف انه ما في clear evidence. بس لما تتكلم مع المريض انه reassurance مع الماسكينج techniques مع خد these medications, يعني I would say in my experience almost 90% will come happy. At least they are happy. Did the tinnitus completely resolve? I don't think so. But at least they can manage their condition in a much better way, and patient at least satisfied. يعني very rarely patient will come after a couple of months ويقول لي والله لسه still same, still bothersome. فإذا تاخده as a holistic كده approach إنه reassurance مع الماسكينج مع need والميديكال ثيرابي والديفرنت precautions زي الكافيين والسموكينج والsleeping, better sleeping, better exercise. يعني I would say 90-95% will at least be satisfied with their management.
احسن ما يروح على العلاجات تبعت الانترنت اللي طق المعلقه جنب ذانك واشياء زي هيك. على
انا
الاقل
مؤخرا كثير قال جوني بيشوفوا في النت الدروبس.
في دروبس، وفي ناس بتطق معلقه جنب الاذن، وفي حركات زي الشعوذه الله فيها.
السلام عليكم.
هذا
بس
رابع.
تعقيبا على حكاية دكتور حسام آخر شيء اللي هي يعني always support the patient. يعني هاي الجملة برضه حكاها وأنا supervisors لما كنت resident. فإجت مريضة منهارة تماما collapsed وكراينج ومبينة depressed، إنه حكي لها أحد الزملاء this tinnitus will خلاص will be lifelong, will not improve at all, it will be part of your life. فعمل معنا محاضرة جمعنا كلياتنا مدة 10 دقائق never اللي هي tell the patient that the tinnitus will stay, will not improve. always support the patient حتى لو أنت متأكد إنه التينيتس مش راح يتحسن. تمام. بالنهاية اللي هي psychological effect بحد ذاته مع ممكن أني بلاسيبو effect ممكن يحسن من نفسية المريض وبالتالي يحسن من التينيتس. بس هاي المداخلة فقط.
You cannot tell 100% that it will not improve. Usually they improve and it become less, or they at least live with it. They will reach to the point that they themselves know that it will not improve. You don't need to tell them, from the first visit at least, for sure.
أو
انت
بتعود.
عارف ايوه دكتور ضرار، بقول لك يعني انت تخيل two scenarios which again happens quite frequent. يجيني مريض يقول لي والله رحت للدكتور الفلاني وكده قال لي في وجهي، قال لي عيش معاه وانتهى الموضوع ما حيروح. ولما انت تيجي تقول له لا ان شاء الله it will improve, we can manage it, خذ هذه الميديكيشن. يعني تخيل التو سيناريو شو الفرق. يعني الثاني بيجيني اصلا ديبرست بيقول لي الدكتور حطمني، قال لي ما حيروح وانتهى وعش معاه يعني هي ما اقول لك عشان كده انت treat the patient as a human عنده condition حتى لو احنا عارفين نعالجها. الكلام الطيب والرياشورنس والطبطبه زي ما يقولوا يعني لوحدها كفيله انه المريض يجيك at least happy satisfied. حيبدا مع الوقت يتعلم انه والله هذا خلاص he will live with it، بس انه حيكون more able to adapt with it in a better way. انا بوصف ترى ميديكيشن حتى الدكتوره قالت psychological. انا اذا يعني حسيت المريض in a very bad situation بعطي anti depressants, انتي اميتريبتالين و other medication يعني quite frequently. ما بستنى حتى يروح يشوف احد. فيعني we have to manage this condition actually لانها ممكن تكون very devastating. ما ادري اذا سمعتوا عن حاله ميشيغان من سنوات طويله، بس صارت المريض كان very depressed، قرر في الاخير انه ياخذ بندقيه الصيد حقته وراح طخ الدكتور وطخ نفسه وانهى الموضوع، انهى التنتس تماما. فيعني يعني we have to be careful. This ترى disease can be يعني فعلا affecting the quality of life quite significant. انا عندي واحده كانت انا ايام ما كنا بدينا الكوكلير امبلانت، بس كان عندها مايلد هيرنج لوس وحولتها فور كوكلير امبلانت لانه كانت يعني in severe depression. يعني كانت تيجي اصلا ماسكه راسها، اولادها يجيبوها يعني ما هي قادره حتى تتكلم معك من how loud is the sound. فهذه حولتها وكلمت الشباب ويعني she was implanted. صراحه ما تكلموني ايش صار، بس يعني سوينا لها كوكلير امبلانت على امل انه we suppress the tinnitus.
الله يعطيكم العافية جميعا. ما بعرف إذا في أي نقاش، احنا تقريبا almost done with the time. في حدا عنده أي final comment or question? Otherwise دكتورة غزل شكرا جزيلا، الله يعطيك العافية ما قصرتي.